So, friends, just a brief introduction. I'm Dr. Sachin Jadhav. I'm based in Bangalore, and I work at my main department is in Trustwell Hospital. But we've been working on improving treatment for patients with hematologic problems and those who need stem cell transplant or bone marrow transplant. We'll be working on this for the last 10, 12 years. What we have done essentially is through the consortium, we've created training programs for physicians, other community specialists, as well as for subspecialists, so hematologists, oncologists, to ensure that hematologic problems can be diagnosed properly and that they can be treated properly. So we have uh, so many new therapies which have come up in the last 5, 7 years. And whether it is the diagnosis and treatment of refractory anemia at one extreme, all the way to leukemia, lymphoma, myeloma, and the various biologic therapies, CAR T cell therapy, etc., which is there. And now, majority of the patients can be cured of most of the hematologic diseases. We conduct such training programs. We conduct CMEs, and I conduct a heme club once in a month. And we also have annual conferences. So we've been doing annual conferences for 7 years now. And our next conference will be in June. I'll, of course, be, informing all of you. Please do attend physically or online our annual conference, which will come up. Now, going forward with this course that we have created, the goal of all the training that I do is that it should be useful in your practice. So even today's talk and the next three talks, which are part of this course, are going to be practically oriented. We are not going to go into pathophysiology. We are not going to go into epidemiology. We are not going to go into, latest mutations, blah, blah, blah. We are going to work on those 90% of patients whom you manage and, essentially discuss how you can better diagnose and manage them in your practice. So, starting off with today's talk, this will be covering the core concepts of complete blood count. And then we will talk about nutritional anemias, which are essentially iron, B12, and folate, right? Three types of anemias. So there'll be a presentation and then we will discuss two cases. When the talk is going on, I request all of you to please mute yourself. And when, of course, the cases are being presented, feel free to put your questions in the chat box and I'll read them out and answer your queries. And of course, we've created a wonderful WhatsApp group, and I'm hoping that going forward for several years, we will keep on discussing patients using these various forums. So, CBC, complete blood count. In some parts of India, it's called as complete hemogram. In some parts of the world, it's called CBP, complete blood picture, whereas in other places, it's called as FBC, full blood count. Essentially, what is done is that this is the first test and probably the commonest test done in anybody's clinical practice, whichever specialty, whichever part of the world that you work in, this is available. And what happens is quite often we do these tests and we have to rely on the lab which is closest to us or the lab where the patient chooses to take the sample and we get a report. And several times we keep on getting confused because patient would have gone to a couple of other labs, couple of other doctors, and will come with a report, which looks very different in different labs. And they'll ask you the question, doctor, why is my hemoglobin over here like this, and in that lab it is like that? And we will discuss some of those scenarios. So, what is very important, especially in the developing world, is whether the report that is generated from a lab is absolutely reliable or not. And we'll come
Right.
to how to identify that. Um, the correct interpretation, a good CBC and one which is interpreted correctly, you are all aware. It can give us some very common basic diagnosis. It can point us towards further testing which is required, and of course helps us in giving treatment and reviewing the patient follow up to see how the parameters have changed. So when we first start, I like I said, I like to start with the reliability part of it, and how do we know that the report which is coming to us is reliable? Now, when you look at any laboratory test, it can be creatinine, it can be thyroid function test, anything. The laboratory errors are divided into pre-analytical. That means
Tudo
all
devagar. Tudo aí, o
requesting the participants to please mute themselves. Yeah, thank you. So there could be problems in which leads to laboratory error even before the test is run. That means pre-analytical. There could be mistakes or errors that could creep in during testing, and then of course there can be mistakes after testing. So let us see before testing what could essentially happen. And this is again divided into pre-collection, during collection, and after collection. How are we handling and storing the samples? So pre-collection, what are the factors which can affect blood test? We've all seen this. We have seen, especially in our country and in most of Southeast Asia and Africa. We are living in a hotter climate. People are dehydrated, and they may come with a hemoglobin which is say 13 or 14, and then when you ask them to drink a couple of liters of water, it comes down to 11. So that is essentially hemoconcentration. That is how dehydration can affect. Similarly, physical activity can affect blood tests, medicines which are being taken. And in this, obviously, antiplatelet drugs such as aspirin, non-steroidal anti-inflammatory drugs, they can affect the platelet function. So that can lead to prolonged bleeding time. Dietary supplements can give you false high levels of vitamin B12, for example, right? So when we are doing this testing, we have to be very sure as to, is the report really correlating with the patient's baseline condition? Um, what about bone marrow test? And as this course progresses, we will be talking more and more about bone marrow. Today, we are going to focus on the peripheral blood. In hematology, bone marrow is a very critical investigation. Uh, Several patients we say, all right, these are your blood tests. Now I want to see what's happening in the bone marrow. That's the factory, you know and what has been done to the patient before they came to me, which can actually affect my bone marrow picture. Now, in this, before we move forward, I would like to say that there are some misconceptions. People believe that somebody has come with severe anemia or low platelets, and bone marrow is required. They may feel that no, 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 I don't want to give a blood transfusion because that can affect the bone marrow report. No, that's not true. So, blood transfusion is a life-saving treatment. Please give it for whichever patient you want. Okay, it is not going to affect a bone marrow report. Now, what about during the collection? Yeah, and we all know that blood is collected from different sites. Typically, a phlebotomist or a nurse or a doctor will take blood from a peripheral vein using a syringe, needle, or a vacutainer. And in this, what happens is many times we apply a tourniquet. What the tourniquet does is it will swell up the vein so that you can easily puncture it. But then before you start drawing, you have to release the tourniquet. Yeah, you have to release the tourniquet, otherwise it leads to again hemoconcentration. Okay, so this is important. If you are taking sample from, say, an IV cannula or a central line in patients who are admitted, typically, you do a lot of testing, and you, instead of poking them every time with a needle, you may just put a syringe to the IV cannula or vacutainer and try to aspirate a blood sample, and that's fine. But when you do that, before you take the sample, you have to flush the cannula with about 5 to 10 ml of normal saline, right? So you're cleaning up the cannula, and then when you aspirate out the blood, the first 5 ml has to be thrown away, because the first 5 ml is going to be mixed with normal saline that you used for flushing. And then you take the subsequent draws to actually send to the lab. In pediatrics, often capillary sampling is done, especially in infants, in NICUs, newborns, right? In that, what happens is you poke with a stiletto or you poke with a needle, and there'll be a tiny drop of blood. And then we try to squeeze the baby's toe or heel, and that can again lead to hemoconcentration. So we have to be careful. It may have a slightly high WBC and neutrophil count as well, a slightly lower platelet count. So as long as we are aware of these things, it's fine. Even when you're taking capillary blood, allow the blood to flow freely so that you get a good sample. Now, what about the technique? How do we, sample the blood? We've looked at the site. If you're drawing blood with a syringe, what often happens is we will, as soon as the needle goes in to the vein, you have released the tourniquet, and then you suddenly apply a lot of suction. So if it's a 5 or 10 ml syringe, you apply a lot of suction, full 5, 7, 8 ml of suction. Now this negative pressure can make the RBCs break, leads to hemolysis, and of course then that will give you a false low HB and aberrant values. At the same time, if you're drawing the blood too slowly, it may start clotting in the needle and the syringe. And, if it's too slow, even before you put it into a anticoagulant tube or vacutainer tube or vial, by then the blood may have started clotting. Again, because part of the cells will get trapped in the clot. So you're going to get a low platelet count, right? And finally, many times, and I have myself made this mistake, we don't use the right type of tube, the right type of anticoagulant. So, thankfully for us, online, now there are a lot of charts available as to for which blood test, which tube, which anticoagulant should be used. So these are the errors that can happen pre-collection, pre-analytical. And what about after collection when you are sending the sample to the lab? Again, we see this a lot because the way laboratories are today, our friendly neighborhood labs do complete blood count. They'll give you a blood picture. They'll do basic biochemistry. They'll do virology tests, HIV, etc. But then a lot of the tests are also outsourced to centralized laboratories. And the centralized laboratory may be in your town, or it may be in Delhi, or it may be in another country. Sometimes when you send some very particular tests, you may have to send them abroad. So how do you store and how do you transport the blood sample? Okay. Before we reach that, it is so important that you label the tube properly, and all of us have gone through miserable examples. So what is actually told is you have to, before what we follow in our department is we ask the patient, what's your name, date of birth, UHID. So I use something called as a 3-point system. So I ask the name, date of birth, and the UHID, the hospital UHID. Or if I don't have the UHID, if it's an outpatient, then I just stick to name and date of birth. I ask the patient, I have to look at the form and I have to write it on the tube before the sample goes in the tube. Okay, that's very important. So you have to label the tube before the sample goes in so that later on there can be no errors. And you have to compare it with the test, the form, as well as ask the patient. I told you the anticoagulant, and there are certain conditions where the anticoagulant may be too much or too little. And one classic example is polycythemia. Uh, you see, what happens is in a vacuum inner tube or any tube which is used to collect blood, a blood sample, there is an anticoagulant. The anticoagulant may be EDTA, citrate, heparin, lithium. These are the common anticoagulants. So they put in a certain quantity, a few grams of anticoagulant. And if you have a 2 ml tube, it has less anticoagulant. It has 5 ml or 10 ml, it has more anticoagulant. Correct? That's logical. However, the anticoagulant is, the amount of anticoagulant is dependent on the assumption that most of the people will have hemoglobin from, say, 5 to 15 grams. Okay. Now, what happens in polycythemia, where, say, hemoglobin is 18 or 19 or sometimes 21? Now, you can imagine I take 1 ml of blood, 1 ml of blood. Somebody has a hemoglobin of 10. Okay. So hemoglobin of 10 means the hematocrit, the packed cell volume, is Hb into 3. So hematocrit is 30% for somebody who has a hemoglobin of 10 grams. Hematocrit of 30% means in that 1 ml, 70% is plasma. Okay? 70% is plasma, 30% is RBC. On the other hand, a patient with polycythemia has, say, 20 grams hemoglobin. 20 into 3, hematocrit becomes 60%. So that means in that patient, the hematocrit is 60% and only 40% is plasma, which means there is very little plasma in a patient with very high hemoglobin. Now imagine less plasma, lot of anticoagulant. What's going to happen? Some anticoagulant will be left behind. So if I put 5 ml of a polycythemic patient's blood into an EDTA or a sodium citrate tube, of course it will not clot because it has very little plasma and there is a lot of anticoagulant powder or liquid in that tube. Correct? It's not going to clot, but there's a lot of anticoagulant left by. And now if I take this tube and do a coagulation test, if I do a prothrombin time or an APTT, that is going to get prolonged. The result is going to be wrong. It's going to be falsely prolonged because a lot of anticoagulant is left in that tube because there is very little plasma. Okay, so these are some things that we see quite often as hematologists. You may not see it so often, but it's important to know that the right tube, right quantity, label the tube properly, and then when you send it to the lab has to store it, right? Most of the times the sample just goes and lies on the table. Nobody looks at it for 3 4 hours, and then somebody after 4 5 6 hours will test it again. Pick it up for testing, and after testing it will again be on the table. And when blood is kept in the environment, it starts getting spoilt, it starts degrading, right? So if I want to keep a sample for 24 hours and say, hey, I don't know, maybe I'll have to recheck after some time, then I have to keep the sample, the blood sample, in a fridge at 4 degrees, not the freezer, not the freezer, below that at 4 degrees. Then the sample will be okay for 24 hours. Even after 24 hours, if I want to do some test, I can pull out the sample and, uh, run the test. So storage is critical. Storage is especially critical if you're going to ship the sample to a reference lab. When a sample is sent, now I live in Bangalore. From here, if I'm sending for a test, even within Bangalore, even within Bangalore, the guy will come from the lab to pick up the sample. He's going to come on a bike and he's going to carry the sample. He's going to shake through all the potholes on the roads of our cities, and it's going to get agitated. There's going to be some hemolysis. And if he does not have a proper box which maintains at least 4 to 8 degrees, it's not going to be perfect, right? But something whereby the sample is transported at the right temperature. then probably it's not going to get spoiled and I'm going to get a more accurate report. Once it reaches the lab, this is another big problem in our part of the world, because not only about the storage, but before the test is done, if the sample has been kept in the fridge, then you have to take it out, you have to warm it a bit to room temperature, and room temperature means 21 degrees. Room temperature does not mean ambient temperature or environmental temperature. Room temperature means 21 degrees. So every lab has to have an AC or something so that the lab processing room is at 21 degrees. Not many places have that, right? And we are aware of that. What to do? We are living in a developing country. Nevertheless, if it is kept in the fridge, you have to ensure that the blood is again mixed again properly and it is warmed up to room temperature before we and do the test. But most importantly, the machine on which the test is done, we have to maintain the quality on that. Now, this is a serious problem. We are all aware of NABL and NABH, and today, many labs try to get accreditation from NABL to show that no, I'm running the quality control, I'm a quality conscious lab, and you can rely on my reports, right? The problem is, most of the labs, unfortunately, will run the quality control only before the NABL inspection, you know, or they'll run it once in 6 months or when the machine is not working, when actually they have to run the QC sample, quality control sample, every single day. Only then you can rely on the reports. And this is one major reason why we get some errors, or some difference in reports from different labs, because they're really not calibrated. QC is not run properly. Uh, we also need to remember what is the normal variation of a machine. So, for example, hemoglobin, a cell counter, the normal variation is about zero point 0.5 grams. Zero point 0.5 grams. What that means is if you take my blood and run it through a proper, good machine with good quality control, you take my blood sample and you run it 10 times in the same machine, the same sample, same machine. You're going to get the report every time, the report is going to be slightly different. This is called as variation. And in hemoglobin is about zero point 0.5 grams or so. It should not be more than that in a good machine. So, sometimes my hemoglobin will be 10, sometimes it will be 10.2, sometimes 9.8. So plus minus 0.5 grams. So that much is the machine error rate, and for platelets, it's about 5,000. So if you take my blood, run it 10 times in the same machine, you will get say 1 lakh 50,000, 1 lakh 55,000, 1 lakh 45,000. So plus minus 5,000, right? So these are normal errors, variations in the machine. We need to remember this as well. Sometimes what of course happens is, you do everything properly, you've collected the sample properly, right tube, right transport, right storage, your machine is very well managed, but you give out the wrong report to the wrong patient. There may be a clerical error. The wrong person's number may be written or name may be written, or many times reports get mixed. And that is why anytime we get a weird report, we will always repeat the test, which is the right thing to do, because errors can happen. So now, assuming the test has been done properly, we need to understand what are normal values and how is this normal value obtained. Why do we say that normal hemoglobin in males is say 11 to 15, and females it's say 10 to 14? Why do we say that normal creatinine is say 0.8 to 1.3? How do we get this normal range? How does any lab know what is normal? Yeah. So how that is done is we take apparently healthy people who don't have a disease, okay, and we put them in control conditions. So they should not be dehydrated. They should not have heavy exercise in the last 20 minutes. They should be lying down comfortably for half an hour, and then you take their blood sample. So these are supposed to be apparently healthy people. And you take blood sample of 100, 500, 1,000 people. Yeah. And you will see that everybody has slightly different report. So somebody will have a hemoglobin of 9, somebody will have 12.5, somebody will have 8.4, right? And not just hemoglobin, every test, WBC count, platelet count, creat, bilirubin, everything. So you measure the blood of several healthy people, and then you plot a chart like this. So for example, in hemoglobin, you may find that majority of the people who have good nutrition, who are apparently healthy, have hemoglobin around 14. For example, okay, this is an example. Slightly less number of people will be at 13.5, and there will be about 16 people in your cohort with hemoglobin of 13, so on and so forth. So you will get a bell curve. You will get a bell curve like this. We've all studied in biostatistics that if you look at the median plus minus 2 or 3 standard deviation. Okay, so this is the median minus 2 standard deviation plus 2 standard deviation, right? So median plus minus 2 standard deviation will give you 95% of the normal population. 95%. If you take 3 standard deviation, it's even more. It's about 97, 98%, right? So that you say is the normal hemoglobin. So then you will say, all right, normal hemoglobin in my group of 500 normal individuals is from 12 to 16. So that's how the normal range is designed and defined. And we need to understand that that's just the population which was tested and it was published. And whether the population is representative, whether there are some, I mean, every time a new test comes, and I remember very well when I was doing medicine, our college had a pulmonary function test, and the standards in the software of that machine for pulmonary function tests were European standards, right? So the FEV1 and FVC and all that are not from Indian lungs, you know. And so it was always said that, well, we don't know what the Indian normal is. And then over a period of time, Indian normal was created for pulmonary function testing, and then that was fed into the software. So you really have to be aware this, normal is not necessarily always perfectly what you would want or what you would expect rather. Genetic background can cause variation, and we have a very particular syndrome in East and Northeast India. East and Northeast India. What happens is many normal people in East and Northeast India, their platelets are bigger than normal. You know, so normal platelet volume, mean platelet volume, that's the size of the platelet, is about 4 to 11 femtoliter. But in Eastern India, many people, the size will be 12 or 13. So they're bigger platelets. They're called giant platelets. And the machine is calibrated that anything whose size is any particle in the blood sample that you have put in, the size is between 4 and 11 femtoliter, it is going to count it as platelet. Anything larger than 11 femtoliter, it will not count it. The machine will think this is a dust particle. So what happens in these individuals is they are normal. Their platelet count is, more than 100,000, more than lakh. But the machine does not count half the platelets because they are larger than normal. And that's a genetic variation. But when you actually do a manual platelet count under a microscope, our pathologists will count big and small platelets, and they will tell us, no, no, machine platelet count is 75,000, but manual platelet count is 1,50,000 because there are giant platelets which are not counted. Yeah. Posture and other things are also there. High altitude smoking, that if you go to North India, if you go to Himachal Pradesh, etc., you're going to see people who are pink. They have a physiological erythrocytosis. Similarly, nowadays, with gyms and protein powders, several people also take hormones. and they may have artificially high hemoglobin because they inject themselves with testosterone for muscular development. That is something that has been creeping up in the last few days, right? And then, of course, it's age. When I joined hematology, I was surprised. Of course, when you're doing your internship, in newborns, the hemoglobin, mean hemoglobin at birth is higher. It's about 18 grams and all that. And as a baby grows, the hemoglobin drops to the adult level. But what I was surprised is in children, especially after 3 6 months, the differential WBC differential has a higher percentage of lymphocytes compared to neutrophils, whereas in adults, neutrophils are more, right? So I would see a lot of lymphocytes in the count and the peripheral smear, and I would think, hey, what is this? Is this a leukemia? Is this a lymphocytic leukemia? Until my senior laughed at me and saying, no, man, in children, physiologically, they have a higher percentage of lymphocytes, right? So all of these are physiologic variations. Mute yourself, please. Okay. Now, whenever you see any report, you have to ask the patient, hey, do you have any old reports? And my every patient's appointment, the first 15 minutes go in getting all the old reports. Many times, patients come to us for a second opinion. They've already visited a lot of doctors and they have multiple files. And they say, no, 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 doctor, I have a lot of files. I don't want to trouble you. I said, no, please don't do that. Give me all the files. I want to look at everything. I want to look at the trend because that trend gives me the story. That trend gives me the story. And I'll tell you as we advance how the story helps me in making a diagnosis, right? So I get the reports, I arrange them date wise. So oldest reports at the bottom, newest reports on top, and then I chart a table to see what has happened to the hemoglobin and the WBC and the platelets. When was it up and when was it down, and what treatment worked and what treatment did not work, right? So it's very important to compare. If patients don't have the reports, I tell them, I'm very sorry, but if you're living close by, please go get your old file from home. Or I write in my notes, get the old file during the next visit because this is just so critical. uh, I can't tell you how many patients get referred to me as ITP. And then when I look at the old records, the platelets have been low for years, decades. And then I ask the patient, they will say, yeah, yeah, doctor, my platelets have been low for 20, 30 years. And sometimes I get people say I have dengue. Sometimes they say I have ITP and they also give steroids. But doctor, even my father's platelets are low. That story. And then I look at the mean platelet volume, the platelet size, and I say, hey man, you just have giant platelet syndrome. You're from East India. We'll do manual platelet count. Your manual platelet count is normal, right? So that story is just so critical. In the case of anemia, how fast is the hemoglobin dropping? That's very important. If there is a rapid drop, for example, somebody comes with severe bleeding from, hemorrhoids, and they're going to come weak and dizzy, the hemoglobin may have dropped from 13 to 11 grams. Okay, but it has dropped very quickly. So the body has not gotten time to adjust. Similarly, sometimes women will come with severe menorrhagia, one period where last 7 days and they're just bleeding like crazy and they'll be feeling very weak. Hemoglobin may be 8 or 9, but still they are very symptomatic, right? Same thing after post-operative or after a road traffic accident. Sudden loss of even small quantity of blood is going to make the patient symptomatic. On the other hand, we all have stories of patient who came with 2 gram hemoglobin and 3 gram hemoglobin and they were very comfortable. And they would also be very brave saying, no, no, doctor, I work in my farm, nothing happens. That's because that person had a very slow drop of hemoglobin to 3 grams, 4 grams, 5 grams over months and maybe years because of little bit of bleeding in the stools or urine, you know, and their body is completely adjusted. And those patients will only become symptomatic, when? When they come to our hospital and by mistake we connect a normal saline, you know, quite often we have this habit, yeah, yeah, just start a normal saline. Now, that person's body, the red blood cell physiology, the heart is already working at peak with severe anemia, 3 grams, 4 grams, and you give 500 ml of normal saline, the heart is going to fail. It's like the straw that broke the horse's back. Already the body, he looks deceptively stable, but you hang, unnecessarily, you hang a normal saline, and the heart cannot, the cardiovascular system cannot handle that 250, 300 ml of normal saline, and they would then suddenly go into pulmonary edema and breathlessness, right? So, that uh, uh, how quickly things happen also matter. Now, just let's look at how we normally test. And you all know that a lot of machines are there. At the same time, a lot of testing can be done manually. There are complex machines which are more expensive, more difficult to maintain, but they are more accurate. And all of us, all of our patients also, they want reports, which are not very expensive. So somewhere we have to figure out which lab near your clinic or your hospital is not expensive, but at the same time has some reliability. You know. Now, one thing to remember, I told you about this giant platelets and manual platelet count and all that. But these machines, automated cell counters, they're made by several companies now. You have the age-old companies, Sysmex and BD and Coulter and all that, and they're phenomenal machines. There are a lot of machines made in India, and there are machines made in China, which are cheaper. I would like to tell you that as long as the machine has been validated, accredited by an international body, today's equipment is very, very accurate. They're brilliant. For example, in this version of this cell counter, a stream of red cells, etc., will go through, and like this, and the cell will count. I mean, the machine will count every cell. It will measure the size, it will measure the granularity, it will put a laser on it, it will put a tiny electric current to it. And these machines are just so accurate. And when they tell you that the hemoglobin is this much, WBC is this much, platelets are this much, as long as your quality control is good and the machine is of a good make, they're far better than manual. Far better than manual. In just a few circumstances, we still look at manual techniques. One of them I told you, if the machine is not reliable, not calibrated, they are not using the correct reagents, or giant platelet or platelet clumps. Other than that, for the large part, your machine is very accurate when it comes to RBC and platelet. WBC differential, we still need to do a peripheral blood smear, and then look at the do a differential count of neutrophils, lymphocytes, look at their morphology, see if they are abnormal. And I can't tell you how many labs, how many technicians, we still can't do the peripheral smear properly. It has to be like this. It shouldn't be uneven. It shouldn't be like this. It has to be stained properly. Only then, when you look under the microscope at this part, you'll be able to see RBC, WBC morphology properly. Yeah. And even for that, they have to use the right stain. Of course, I'm not going to get into the details of the staining techniques, but what I can tell you is, stains are there for the DNA, RNA, and the cytoplasm. Generally, they're contrasting stains, and that's how we can see the cytoplasm, cell membrane, and the nucleus. And if this is done properly, majority of the pathology colleagues or friends can give us fantastic reports just on the CBC. Now, let's come to our, moving towards application of this towards our areas of interest. And as we transition to that, I would just like to tell you something about peripheral smear. A lot of us, we've been taught since MBBS that peripheral smear is so important. and it gives us so many diagnoses. But my problem is that every report that you read, the RBC morphology is reported as aniso 1 plus, poikilo 2 plus. And what is this 1 plus, 2 plus, 3 plus? It doesn't mean anything. You take anybody's peripheral smear, the cells are going to be uneven. They are going to be of different size. They're going to be of different shape. You don't have to mention that. You should only mention a good pathology report will only tell you what is important. For example, in this peripheral smear, okay, you see this is the lymphocyte and these are the red cells, right? And these tiny dots are the platelets. Now the red cells, if you see, this red cell looks normal. It is nice, round, with, a pallor in the middle. But then other red cells are either too tiny, okay, or they are normal size, but the pallor is a lot. Pallor is very big. What does that mean? That means there is very less hemoglobin in it. You know, now red cells are phenomenal cells. They are unlike any other cell in biology because they are like a donut. It's like a donut shaped balloon. It's like a balloon, you know, and the balloon which carries hemoglobin. That's it. It doesn't carry anything else. The red cell does not carry RBCs, the nucleus. It doesn't carry anything. It doesn't have granules. It is just a balloon filled with hemoglobin. So if there's less hemoglobin, the cell will be smaller, or if it is bigger, the central pallor will be wide because there is very little hemoglobin in that balloon, you know. So if I look at this, I can make out that there are these cells and there are these cells. And I can then guess that maybe these tiny pale cells with a lot of central pallor, less hemoglobin, right? Different sizes, and maybe these belong to the patient. And these normal looking cells, probably the patient has had a blood transfusion. So maybe this is an individual who came with a hemoglobin of 4 grams, got blood, and these are the normal looking transfused RBCs from the blood donor. Okay. So you see, good staining, good smearing tells me a lot. You know, that's how a red cell is. It's just a bag of hemoglobin, like I told you. Now, what is important is one of the commonest questions that you have. Iron deficiency anemia is so common in our practice. And every now and then you think, hey, my patient I'm treating with iron, but hemoglobin is not recovering. Does this person have thalassemia? Okay, especially in children. And if you look at the peripheral smear report or even the cell, CBC report, they look exactly the same in iron deficiency and thalassemia. In both, the MCV is less, hemoglobin is less. Yes, in thalassemia, RBCs may be high, but low MCV, that means there are smaller cells. Smaller cells means there is less hemoglobin, you know, and both can have these target cells. So, how do you differentiate between iron deficiency and thalassemia? Now, what is important is if you look at iron deficiency, every cell, every cell is damaged, it's abnormal. All of them are almost of the same size. All of them are small, all of them are almost of the same size because thalassemia is a genetic disorder. What that means is this patient was born with a defect in the hemoglobin gene. There's a mutation. So every RBC produced in any bone marrow, any bone of the body is going to be abnormal. Okay, that's thalassemia. That's an inherited disorder. Whereas in iron deficiency, what happens is, as the person becomes deficient, some part of the marrow may still have some iron left, other part of the marrow may have no iron left. So then RBC made in this part is going to be very small and very pale. But an RBC made in this part may still have a slightly bigger size and may still have some hemoglobin, right? Because it's an acquired disease. So there is patchy loss of iron throughout the bone marrow, right? And this is seen by something called as RDW. RDW. In your CBC report, next time you should see if your lab is giving you the RDW. which is the red cell distribution width. That means if the cell counter does is it will make a graph of the size of the RBCs. The size of the RBCs. There are some RBCs which are very tiny, some are big, some are in between, right? Now you can imagine what will happen in iron deficiency, because there is blood cells made from different parts of the body, different marrow sites. Some will be small, some will be large. You're going to get smaller cells and bigger cells. So this curve RDW is going to be wide. Red cell distribution width of that curve RDW is more than 17. Just remember this number, 17. So if your RDW is more than 17, that means it's probably iron deficiency, because your RBCs are different sizes. On the other hand, in thalassemia, it's a congenital disorder. You see, every cell is pale, but all of them are almost of the same size. There's not much variation in size because it's a congenital problem. Hence, the size when you plot, it's a narrow curve. Your RDW is going to be small. This is one of the things that can give you this idea. But again, it has to be pre-transfused. You shouldn't get a child who's already had a transfusion. Yeah. So you have somebody with anemia, low MCV, okay, RDW more than 17. You would think iron deficiency, and you'll be right. Most of the time, you're going to be right. And in your practice, you may say, hey, this looks like iron deficiency. I'm going to treat with iron. Sure, no problem. But if you want to confirm, you only need to do one test, and that's ferritin. That's it. Don't do the iron profile. Don't do the serum iron and transferrin and TIBC. It's only going to confuse you. Ferritin less than 15 or even 25. Some places they say 25. There is no other differential diagnosis. Ferritin is the storage part of iron. If you don't have any ions in the store, there is iron deficiency anemia. Ferritin less than 15 or even less than 25, it's iron deficiency and nothing else. Okay? You can comfortably go and treat. Yeah? Maybe it is a thalassemia patient with iron deficiency. It's possible. But ferritin less than 15 is iron deficiency and nothing else. Okay? And if you have any doubts, you correct the iron and then you actually do the test for thalassemia. You do a hemoglobin electrophoresis. It will tell you if the hemoglobin is normal or abnormal. Yeah. Now, briefly, just as an example, we peripheral smear, we also look at neutrophils, and they can give us some idea what is happening. Any cell that does not look normal, in pathology, it is called as dysplasia. Anything that does not look normal is dysplastic. And if there is dysplasia in the WBC, that means you see normal WBCs have these granules, these dots in the cytoplasm. This patient's WBC does not have the dots. So this is called as a hypogranular. These WBCs have less granules. So maybe there is dysplasia. And maybe that dysplasia of the marrow, myelo means marrow, myelodysplastic syndrome. Yeah, dysplasia of the marrow cells, and marrow is the factory which makes RBC, WBC. So maybe if the WBCs are showing dysplasia, maybe anemia is because of MDS, myelodysplastic syndrome. That means the cells are not normal. How can it produce blood? How can marrow produce blood? So these are some pointers, but they're okay. And sometimes what will happen is you will see younger WBCs in the blood, younger WBCs. You see, in the bone marrow, the stem cell is the seed, and that seed gives rise to myeloblast, promyelocytes. That's how the WBC develops. And at one point, band cell stage, the WBC comes out of the marrow and starts floating in the blood to do its job. Okay? What that means is the WBCs are the soldiers. So the marrow has these young soldiers who are still in training. And once they have matured to a band form neutrophil stage, they're going to escape from the army school and come out into the field. They're going to come out in the blood to protect the body. But if you are seeing younger soldiers in the field, If you are seeing myeloblast, promyelocytes, there is something wrong. Why is the body sending young soldiers? Is there an infection? Is it cancer? What's happening? So that's called as left shift. Okay. And sometimes, of course, your pathology colleagues will write atypical cell scene. Atypical cells usually mean an abnormal looking WBC. It may be atypical myeloid, lymphocyte, neutrophil, monocyte, whatever. But anytime they write atypical, your brain should go on alert because it could be a cancer. It could be a cancer. So whenever anybody says atypical cell or query atypical cell seen, don't assume it's nutritional anemia. It may be viral, right? But you have to evaluate further to ensure that you're not missing an underlying leukemia. So these are some pointers, overall, our ABC of CBC, that means the core concept of complete blood count. You might have noticed I haven't gotten into other details. I'm not talking about reticulocyte and reticulocyte production index. I mean, how many of you actually get a reticulocyte count? And how many labs near you can actually give you a reliable reticulocyte count or whatever it is. So my entire training is based on what you get and how are you going to use that to best manage your patient. So now let's move on to somebody who comes to you with anemia and how do you approach that patient. If you want, we can take a small break for 5 minutes and then reconnect. In between, if you want to talk or ask something, feel free. Oh, you guys can't hear me?
Sir, excuse me, sir, I'm Dr. Suswami.
Yes, sir.
Sir, that environmental pollution, maybe water pollution, air pollution, and radiation, all those are have impacted on the hematological abnormalities compared to the previous year, sir. I
Not a
mean to
lot,
say
sir.
that the recent,
Not a lot. So we know
not
that
a lot.
not a lot. We know that
We
environmental
are
toxins,
statistics.
yeah, environmental
Hmm.
toxins can lead to endocrine problems. We know there are microplastics, but as far as broader hematology is concerned, maybe it is leading to
Hematological.
some problems, yeah, but not much.
So, good evening,
Uh,
sir. How do
yeah.
we
Go
differentiate between
Because
anemia
in
of chronic disease? I mean, if in that case we have to do a TABC, right?
How do we differentiate between?
Iron deficiency anemia and anemia of chronic disease.
Yes, and we will come to that. We will come to that. So, my problem is today I am seeing, previously everybody used to treat anemia without even today, we are forced to just treat based on CBC. Patients don't want to do any test, and you give iron tablets, etc. Now, at least a lot of our friends are doing iron profile. My problem with this iron profile in Indian labs is they don't do ferritin. You know, I mean, that's the most important thing. So if you want to look at, and we are going to come to that in the next few slides. If you want to look at iron deficiency, do ferritin. Ferritin less than 25, iron deficiency, nothing else. Okay, of course, there are rarer syndromes. Forget it, you're not going to see that. So do ferritin. Okay, now you've given iron tablets or injections, and your ferritin has become normal. It's more than 25 now. Okay, and you don't know why hemoglobin is not coming up. Then you do iron profile. But if you do it before, you will not get a perfect diagnosis and you're only going to get confused. So we should know when to use which test. And it's cheaper to do ferritin. Okay, I'm reading the questions. Dr. Kritika Ganesh has asked, what about Segal's index and Menzer's index? Good question. They were all very important. When they are important if you're doing a community screening for thalassemia. What that means is You know, there are certain communities where thalassemia is common, and you can't do HB electrophoresis, that's hemoglobin electrophoresis, for everyone. So then you do a complete blood count, you calculate the Menser index or Segel index, and then decide, all right, this person, I'm going to do hemoglobin electrophoresis, right? So it's for a community screening. For general practice, you do CBC, you look at MCV, RDW wide, do ferritin, okay? And if you suspect thalassemia, you have to do hemoglobin electrophoresis. Why would you waste your time looking at Menser's index? And nowadays a lot of labs give this unnecessary variables, parameters, which truly don't help you with diagnosis. So just do the test which is required for diagnosis. We have a question: if sample is stored at 4 degrees, can we get correct platelet value? Of course, provided you warm it and you keep it on a roller to mix the sample properly. That is what every good lab does. What happens if CBC sample is tested immediately after collection? No problem, you should. But if you're not testing it immediately, you should store it at the right temperature. Uh, uh, yeah, so Dr. Kritika has written more about Menser index, but again, you do ferritin. If not, you just do hemoglobin electrophoresis. When you have a patient in front of you, you have to tell them, is it thalassemia or not? And at that point, you can't use any index to discuss. You just have to do the test and get the report and counsel them. That's it. That's real medical practice. Any other question?
In ITP, is the mean platelet volume is indicator for ITP, mean platelet volume,
Sorry?
المين platelet volume in
Yeah.
ITP.
No. We use
ITP
mean platelet volume for the giant platelet syndromes. See, ITP again, we all try to look at various surrogate indices. We look at the immature platelet fraction and this and that. If you're thinking of ITP, you have to do the bone marrow, get a diagnosis, and then start steroids. That's it. Anything else that you do is only going to delay time, cause you stress, and cause stress to the family. It's very important to just do the right test and get the diagnosis.
in ITP we may say some giant platelet
I
in the
mean, giant
smear.
platelets are seen in so many, you just ignore it. If you're thinking of ITP, you have to go ahead and do the marrow. That's it. Nothing else is going to help you with that diagnosis.
Thank you.
Yeah. All right. So let's
Sir,
move.
you are mentioning pre-analytical and post-analytical errors and all. So can we get the errors? No, like by looking at the CBC report only.
No. That is the reason why whenever you get, for the first time, you get an abnormal report, you repeat it because you want to be sure that there is no error.
Okay.
Yeah. That's all. I'm just making
साले
you
की zoom audio साले पर भी audio
I'm just making you aware of the various factors that pre-analytic and that may affect and give you a false report. Okay, so Neeraj Narsipur, is bone marrow must for ITP? Yes, it is a must. Anybody who says is not a must, sure, if you're not going to treat it with steroids or other immunosuppressants, if you're going to give IVIG, then maybe you don't do the marrow. But if you're going to treat with steroids, you have to do a marrow because you don't want to miss a leukemia. Remember, steroids can confuse the diagnosis, can affect the bone marrow, and mask the diagnosis of leukemia. So if you're not treating with steroids, you're only going to do IVIG, maybe you don't need a marrow. But the moment you say, okay, I'm going to use steroids or immunosuppression, you have to do a marrow to show that it is normal and it is not aplastic anemia or a leukemia that is evolving. Okay. Ferritin is an acute phase reactant. How reliable is an ITA? I did not tell you how to interpret high ferritin. Okay. When ferritin is high, I told you look at iron profile. But ferritin less than 25 is nothing but iron deficiency. Okay. So ferritin less, it gives you the diagnosis. Ferritin more, you have to do further tests. Okay, that's a good question. So ferritin is high, you don't know what's happening, but ferritin low, there's nothing but iron deficiency. Internal QCs are running on analyzers. So, okay, that's okay. Why will HB be low in hypothyroidism? Good question, and I'm happy Dr. Sachin Kumar has asked this because I'm not going to touch upon this in the further lecture. Hypothyroidism. I'm just giving you basic concept. I am not an endocrinologist. My wife is an endocrinologist. But the way I look at it, the way I taught myself in MBBS, is hypothyroidism means your body does not have petrol. So everything is running a bit slowly. Everything is subnormal, right? And that's why the marrow production is also subnormal. Okay? You may have enough iron and B12 and folate, but if you don't have the thyroid hormone, every cell in the body is a bit slow. And that's why there is anemia in hypothyroidism. Any HB variation in elderly? No. Physiological, pathological changes in elderly? Nothing. Beyond teenage, well, even less than that, beyond say 8 9 years, there are no further age related variations. Cold agglutinin, how do we keep sample at 37 degrees? Yeah, so that's interesting. It's a very rare problem. You get cold agglutinin hemolytic anemia, and I'll come to you in the hemolytic anemia talk how we take the sample. Sandeep Raj, hi Sandeep from Maldives. Thanks for joining. Any HB variation in elderly? No. Then does IVIG affect marrow picture? It does not. That's why if you're thinking of ITP, you don't want to do marrow, you can only give IVIG. Anything other than IVIG, you have to do marrow. Range of maximum platelet count after GCSF. GCSF is granulocyte. You are increasing WBCs. Platelets are not supposed to increase with GCSF injection. All right. So now let's proceed with the next half of the talk, and let's look at anemia. Now, there is a concept of cytopenia that I would like to tell you. And I've said this a couple of times in the last 1 hour that bone marrow is the factory. Bone marrow is the factory which is there inside our bones, and this factory makes the blood cells. So it makes the RBCs, it makes the different types of WBCs, and it makes the platelets. How they are made is very interesting. In the bone marrow, we have something called as a stem cell, hematopoietic stem cell, the stem cell which makes blood cells. Hyma is blood, poiesis is creation. The stem cell which creates the blood cell is hematopoietic stem cell. Now, this hematopoietic stem cell is a seed. It's a seed. And this seed will create the entire bone marrow. Like the seed of a plant, creates the whole plant. It creates the flowers and the fruits and the trunk and the roots. Similarly, this stem cell will give rise to marrow, which will give rise to RBCs and WBCs and platelets. Okay, this is the factory. Now, why am I telling you this? You will see. Before we go there, let us see what is normal hemoglobin. Okay, any hemoglobin less than the range given in the report. So if your lab says that the range is 11 to 15, anything less than 11 is anemia. Okay, so anything less than the normal range is anemia. But if the hemoglobin is more than 10, we call it mild. Up to 8, we call it moderate. Once it starts going close to 6, we start saying, hey, this is severe. Survival may be a problem. Survival may be a problem when the hemoglobin starts going below 8. And when it goes below 6.5, it's a life-threatening problem, especially if it is acute anemia. Okay, so more than 10, less than normal range is anemia. More than 10 is mild. Up more than 8 is moderate. As it starts dropping below 8, it's severe, and less than 6.5, life-threatening. And that is why we only give blood transfusion once the hemoglobin goes below 8. Okay, so we don't give blood transfusion for the large part for somebody with a hemoglobin of 9 or 9.5 or 10 because it's mild anemia, right? Only when it starts going beyond moderate, starts going to severe, that is less than 8, should we start giving blood transfusion. Now, somebody has anemia, okay, which means obviously there are two broad problems. Either the production is a problem or there is too much usage, there is destruction. Let us look at a production problem. Production, okay, which means first cause, commonest cause is your factory is not getting the raw materials that it needs. The bone marrow needs iron and B12 and folate. It also needs proteins, right? But the most important is iron and B12 and folate. So maybe first commonest cause in your practice is what you diagnose must be iron deficiency. And you're right, because poorer country, nutritional issues, you know, and then of course, like somebody else said, it might be that the raw materials are there, but there are other things in the body because of which the marrow is not able to produce blood. So anemia of chronic disease. So this is a production issue. Sometimes what happens is that genetically there is a problem, which is the next thing that you look at. Low MCV, iron you have given, hemoglobin not improving as much as you want, you start thinking of thalassemia. Maybe there is a mutation in the hemoglobin gene, right? Third, raw materials are there, genetics okay, but the marrow has failed. Either the marrow does not have workers, the factory does not have workers. So it's aplastic anemia. In aplastic anemia, RBC, WBC, platelet, all three go down. When only RBC production is down, we call pure red cell aplasia, PRCA. Okay, so the marrow does not have workers, or the workers are there, but they are abnormal. They are not effective. They can't do their job properly. They are dysplastic, myelodysplastic syndrome. Or the workers have been replaced by bad guys. So your good workers have been replaced by bad guys and they are creating chaos. It's a cancer cell, leukemia, lymphoma, solid tumor metastasis, you know, and these have infiltrated, and now the poor workers don't have space to do their job. So the production has come down. So these are the four conceptual, how I look at anemia. Reduce production, maybe one of these three. Maybe the production is okay, but there is increased requirement or increased destruction. You know, blood loss. You see this every time. Majority of the women in the childbearing age group with anemia are going to have iron deficiency due to menorrhagia. What is interesting is most of the women who have menorrhagia from menarche, from the time their period started. And from menarche, they may be having menorrhagia, but for them, that is normal. So you ask them that, okay, do you pass blood clots? They say, yeah, but that has been there since childhood. Okay. One way of knowing whether a woman has menorrhagia or not, we can no more ask, how many pads you change. When we were doing MBBS, we were taught the number of pads used per day. But now there are different kinds of pads. There are absorbent pads which can absorb far greater volume of menstrual blood. So we can't really count the number of pads. What we can see, however, is when things go wrong, when they are abnormal, when they are unnatural, the way nature has created uterine biology. Okay, there is menstrual bleeding, that is, the uterine lining is shed. A clot is formed. A clot is formed in the uterus, and then the clot dissolves and liquid menstrual blood comes out. Okay, that's normal. That's normal. So there's shedding of the uterine lining, clot formation, clot dissolves, and then the menstrual blood comes out. In menorrhagia, what happens is clot, and there are so many clots that all of them can't be broken down. They can't be dissolved. So some clots start coming out along with the liquid menstrual blood. So whenever there are clots in the blood, there is menorrhagia. This lady is bleeding more than normal, and that can explain iron deficiency. Yeah, you may want to test, why is there menorrhagia? Is there a coagulation problem? Is it PCOS? That's a different issue. But there are blood clots, means there is excessive menstrual bleeding. Other blood loss that we of course look at is gastrointestinal loss, especially microscopic, as many times people don't know that they are losing blood, and chronic blood loss, severe iron deficiency happening over months and years. And then another type of blood loss is the RBCs are just breaking. RBCs are breaking. They're breaking in the blood vessels, they're breaking in the spleen, but they're breaking. That's hemolysis, and we have a separate talk on that. So we'll come to that. So, how do we evaluate somebody who comes to us with low hemoglobin? I told you history. How acute is it? When did it start? Are you symptomatic? Did you by chance see a low hemoglobin on your routine health checkup? Or you went for a surgery and pre-operative checkup? You saw hemoglobin is low. Okay. That tells me how urgent the problem is. I will also ask about symptoms of anemia, and you all know the symptoms of anemia. So, if there are no symptoms, it means it's a long term problem, chronic anemia. Okay. I will also ask about whether this has happened in the past. Now, there is one peculiar history that you will get in nutritional anemia, very peculiar. Okay. Iron deficiency, B12, folate, anything. People get anemia, hemoglobin goes down, they go to a doctor, the doctor gives blood transfusion or gives oral or IV iron or gives MVBC, multivitamin B injections. The hemoglobin goes up to 10, 11, and then after 2, 3 years, it again comes down. Okay. So recurrence of anemia every 3, 4 years. Recurrence of iron deficiency, B12 deficiency every 3, 4 years is classic. Why does that happen? Because when you give blood transfusion, one packet of blood, one packet of packed red cell has 1 year supply of iron and B12. 1 year. So when you give blood, okay, of course the hemoglobin immediately goes up. But the transfused RBCs also have a lot of iron and B12. And that iron and B12 will go and spread in the body. And the B12 will sit in the liver and fill up the store. So after transfusion, if it's a B12 deficiency, for example, patient comes to you with 4 gram hemoglobin, you're given 2 packets of blood, then you check hemoglobin. Hemoglobin has gone from 4 to 6. Patient says, okay, doctor, you discharge me, I'm feeling better. You discharge the patient. After 2, 3, 4 days, when the patient comes back with repeat CPC, that 6 has become 8. And you think, how does 6 become 8? With transfusion, 4 became 6. How did 6 become 8? Because those RBCs had a lot of iron and B12. And that went into the marrow and gave it the raw material. And then it packs it up for 1 year, 1 year supply. And from second year again, iron and B12 starts going down. Third, fourth year, the hemoglobin starts coming down again and the patient comes again. So that is recurrent nutritional deficiency. Okay. This we will know only on history, nothing else. Okay. If hemoglobin is down, I want to see what's happening to the RBCs and platelets. So I'll ask, do you have fever, cough, cold, any urinary problem, weight loss, any bleeding? With that, I understand whether it's just a hemoglobin problem or both. Okay. I told you about acute and chronic. We ask for fever, weight loss. This is important because I want to rule out, GI malignancy. I want to rule out an underlying hematologic malignancy, lymphoma, leukemia. I want to rule out if there is malabsorption. I have a patient with recurrent iron deficiency, and I start my consultation by, like I told you, by looking at all the old reports and telling me, okay, tell me your story. Oh, doctor, this happens and that happens, and I have this stomach discomfort, and I have gastric problem, gastric problem, gastric problem. What gastric problem? I don't know, doctor. And then I did an endoscopy, and we found out that he actually had celiac disease. So the celiac disease was leading to malabsorption and iron deficiency. So these few 5, 6 questions that I ask, which help me ensure that I'm not missing anything major. Then of course you look at general CVSRS, just a general system review. Clinical examination, there's really nothing much in hematology. You look at pallor, but I'm not very good at pallor. I mean, severe pallor I can make out, but I've never been as good as my friends in saying, hey, this is 7 gram or this is 9 grams. I can't make out. I would rather just look at the blood report. And For leukopenia, so we look at the lymph nodes, liver, spleen, any bleeding spots. If there is icterus, that tells me it may be hemolytic anemia. Okay. Lymph node, liver, spleen tells me that there may be an infiltrative disorder. It may be a leukemia or lymphoma where the bad cells are infiltrating the factory. Yeah. So this is the only examination. There is nothing much. In investigation, you do an automated cell counter, and like I told you, it will tell you the WBC, it will tell you some differential. It will tell you the hemoglobin, the size of the RBC. Yeah. So is it small or large? Small is microcytic or macrocytic. That's it. Don't worry too much about other things. Okay. Look at the RDW. If RDW here is 15.8, that's okay. If it was more than 17, I will think this is iron deficiency. So low hemoglobin, MCV 60, 65, RDW more than 17, iron deficiency would be my first diagnosis, first differential diagnosis. Then I look at the platelet. See, some cell counters will give you the platelet volume, MPV, but we are not looking at platelets today, but I'm just pointing it out. So I am seeing iron, low hemoglobin. Suppose your MCV was low, suppose RDW was wide, I would say iron deficiency. But then why are the platelets high? Because in iron deficiency, there is reactive thrombocytosis. Platelets, platelets are also acute phase reactant. Just like your ESR, CRP, and ferritin, platelets are acute phase reactants. Platelets will go up in infection, sepsis, inflammatory disorders, and iron deficiency. Okay? So, in this case, in this particular report, there is no microcytosis. RDW is less than 17. I am not thinking of iron deficiency. Then why is platelet high? WBCs are also high. Maybe there is some infection going on. So this is how our brain will work when we look at CBC, and we'll come to more examples of this. Okay. Of course, when you report, look at anything, you have to look at the physiological variation, and then you call up your pathology friend and you say, hey, can you do a peripheral smear? I have a patient with anemia, and they will say, okay, what are you trying to find out? I'm trying to find out, if the WBCs are okay, platelets are okay, are the RBCs small? Okay, is there anisocytosis, or do you think it looks like thalassemia? Is there malaria? Last week, we found out one person with chronic anemia actually had malaria. And you know how the malaria was diagnosed? In the bone marrow. I mean, it was so stupid, right? He didn't have fever, but he had chronic false falciparum. And a wonderful hematopathologist, he picked up malaria on the bone marrow, right? But even on the peripheral blood, some pathology friends will tell us, hey, there's just malaria and nothing else. They will tell us if there are atypical cells, in which case you have to be alert. Maybe there is a leukemia or some other malignancy. Yeah. So you've done your complete blood count, you've looked at the peripheral smear. If you think it is iron deficiency, you can initially treat if there is no severe anemia. You can do a ferritin, okay? But there are some patients where you have to do more tests, and I'll come to that. Now, what are the more tests? What do we do? So you have done your bit for anemia. You've given iron, you may even have given blood transfusion, you may have given vitamin B injections or tablets, and then they come to us. We look at LDH. Now, LDH is a very fantastic enzyme. It is an intracellular enzyme. It is in all the cells. It's in RBCs, WBCs, anything. And when the cells break, the LDH in the cytoplasm comes out in the serum. So if the serum LDH is high, that tells me that cells are breaking. Why are cells breaking? Maybe there is hemolysis. Okay. Maybe there are cancer cells which are multiplying and breaking, rapidly multiplying, rapidly dying. Okay. And third, B12 deficiency. What happens in megaloblastic anemia, B12 folate deficiency, is the cells in the bone marrow, in the factory, the immature cells, they need vitamin B12 folate, for the DNA to become mature. The DNA to become mature. Now, when these vitamins are not there, the cells become bigger and bigger and bigger in size, but the DNA does not mature in the nucleus. So, after some time, the cells will die. They die inside the marrow, intramedullary hemolysis. So the RBCs and WBCs, the RBC, immature RBCs, they are trying to grow. There are no vitamins. The DNA cannot mature, so they break. And in the marrow, there will be lot of cells, but they are all dying there. That will increase the blood LDH to thousands. So when LDH is high in anemia, hemolysis, malignancy, vitamin B12 deficiency, you know, is in B12 we have seen LDH in thousands. I will also, of course, do an LFT. I'll see if the bilirubin is high, is there hemolysis? If the globulin is high, I'll think, hey, maybe there's something rare like myeloma. What about the kidneys? Is it anemia of chronic disease, anemia due to CKD, right? Or is it an acute TTP, HUS-TTP like problem? That's what creatinine tells me. If I'm thinking of hemolysis, I will do a Coombs test, direct Coombs test. And then if I'm thinking of a malignancy, a leukemia, because LDH is high, abnormal WBCs are there in the peripheral blood, or the WBCs platelets both are down because production is down, then I will do what we call as tumor lysis marker. So we do uric acid, calcium, phosphorus. You don't have to know that so much. Now, coming to some particular features of iron deficiency and B12, because that is what we're going to look at today. Like I said, every 3-4 years, the patients have slow drop in hemoglobin. Otherwise, examination is normal. No lymphadenopathy. I mean, of course, pallor is there. No lymphadenopathy, liver, spleen are not enlarged. Maybe a bit breathless. Elderly patients may be having some cardiac failure because of severe anemia. But liver, spleen, lymph nodes are okay. Smaller RBCs, so small, low MCV, mean corpuscular volume, different sizes. So RDW is more than 17. Other cell lines are normal. So white cells, platelets are normal. Okay. How do you diagnose? Like I said, ferritin less than 25, nothing but iron deficiency. But if this is high due to whatever reason, then you do iron profile. You don't need to do it routinely. Okay. And if your diagnosis of iron deficiency, etc., is not fitting, then you do LFT, create LDH, and they have to be normal for you to make a pakka diagnosis of iron deficiency. If you're still not sure, if you maybe there is small sized RBCs, small MCV, RDW is also small, you think you have thalassemia diagnosis, then you have to do hemoglobin electrophoresis. However, when you do hemoglobin electrophoresis for thalassemia, the patient should not have received blood transfusion within the last 3 months. Why? Because there will be transfused RBCs in the body. And half-life of RBC is 100 to 120 days. Okay. So if somebody has received blood transfusion and you want to rule out thalassemia, don't do hemoglobin electrophoresis. Wait for at least 3.5 months for the transfused RBCs to die. Then you can do hemoglobin electrophoresis. However, if the patient is continuously requiring transfusions and you can't wait for 3 months, then do a genetic test, do a mutation analysis for thalassemia. Okay. Some specific features of B12 and folate is the same thing, slow drop every 3-4 years. On examination, everything else is okay. RBCs are bigger than normal, MCV is high. But if the MCV is very high, more than 120, okay, so 80, 85, 90, 95 is okay. But if the mean corpuscular volume, the average size of the RBC is more than 120 or 130 or 140, it is physiologically not possible. RBCs cannot become that big, they will burst. So when you get, if your cell counter report tells you that MCV is 125, it cannot be megaloblastic anemia. RBCs can never become that big. What that actually means is the RBCs are sticking to each other. They're sticking to each other. And that is why they look big. And the cell counter will say, okay, this is the cell counter does not understand that these are multiple RBCs sticking to each other. It will think it is one large RBC and give you a false high MCV. So when you get this crazy high MCV, there's only one diagnosis. It means RBCs are sticking to each other. Autoimmune hemolytic anemia. Autoimmunity. The patient has antibodies against his or her own RBCs. And these antibodies are making the RBCs stick to each other into a ball, right? Autoimmune hemolytic anemia. When we see MCV of 120, 130, we know, hey, this is anemia. This anemia is not megaloblastic. It is autoimmune hemolytic anemia. So autoantibodies which are breaking your own RBCs, making them stick to each other. Yeah. In B12 folate, even the WBC and platelets can be low. Okay. Because B12 and folate is required for DNA development even of the WBCs and the platelet megakaryocytes, precursors. So even WBCs may be about 2000. Platelets may come to 30, 40,000. So not only do you have anemia, you start having WBC and platelets also low. At that point, you have to call your pathologist and ask, hey, are there any abnormal WBCs? WBC count is low. Is it because there is cancer in the marrow? Are you seeing any atypical cells? They say, no, 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 I am seeing proper neutrophils. The differential count is okay, but total WBC count is low. Then you have to ask them, okay, how do the neutrophils look? Neutrophils should have 5 lobes. If they have more than 5 lobes, if there is even one neutrophil in the peripheral smear with 6 lobes, it is polymorphonuclear neutrophil. That means the neutrophil has multiple lobes, more than normal. And then you start thinking of megaloblastic anemia. Okay. So large RBC is not very large. Maybe WBC platelets are also slightly low, but the WBC differential is normal. You're not seeing any atypical cells. Your pathologist tells you, yeah, I'm seeing neutrophils with 6 lobes, polymorphonuclear. You can treat it as B12 folate. My suggestion is you send off a B12 or folate blood sample. Okay, send it off because you have to get a diagnosis. If you don't get the diagnosis, how long are you going to treat? How will you know? You know, of course, in some patients you can't send this, so you treat. Okay, but if possible, you send off serum B12 folate level. However, if you're going to give blood transfusion, take the sample for B12 folate before transfusion. Or if transfusion is already given, I call the lab and say, hey, do you have yesterday's blood sample? By chance, some good technician may have kept a biochemistry sample in the fridge. I say, okay, pre-transfusion sample is there in the lab. I'm going to do a B12 folate on that because once transfused, I told you one pack of blood has 1 year supply of B12. So you'll get a false high level. As I said, in B12 folate deficiency, the RBCs are not able to mature, RBCs, WBCs. They'll burst and die in the marrow, and hence the serum LDH can be high. Again, other organs are okay, LFT creat is fine, and when you give blood, after 3, 4, 5, 7 days, everything starts improving. You've given packed red cell, but after 5 days, even the WBCs and platelets start increasing because those packed cells had a lot of B12 in that, right? So that deficiency is getting corrected. And now, this is the most important thing that I want you to understand. I have coined this term called high risk cytopenia. High risk cytopenia means which patient are you going to evaluate further? Which patient of anemia are you going to evaluate further? So it is not just RBC, even WBC or platelets are down. So more than one cell line is affected. No response to iron or vitamins. Or there is a response, but now there is recurrent anemia or recurrent low WBC platelets. So recurrent cytopenia. Okay. Function of WBC is also a problem. So there are recurrent infections. Or you're treating with iron B12, but the recovery is not fast. The recovery is delayed. Classic example in dengue fever, low platelets should start recovering in 2 weeks. If they are not recovering, then it's not dengue fever. From the onset of fever, in 2 weeks, if the platelets are not recovering, it's not dengue fever. It is prolonged cytopenia. You have to do a marrow, maybe a leukemia or aplastic anemia, maybe ITP also, who knows? But you have to evaluate. If the lymph nodes, liver, spleen are big, you have to evaluate. It may be an infiltrative disorder. If your pathologist tells you there's any atypical WBC or there is a left shift in the peripheral smear, and for whatever reason you're going to give steroids. So, stop giving steroids before all blood transfusion. It is not required. Okay, we never do that. So stop. Many of us are in the habit. We'll give one hydrocortisone before every blood transfusion. Please don't give. It's steroid. It's not a simple drug, and it can mask the diagnosis of leukemia. So if your patient has any one of these, then don't assume that it is nutritional. This person needs further evaluation. We have to look at the factory. If the lymph node, liver, spleen are big, we may have to do other tests, PET, CT scan to see whether there's a lymphoma. Okay. And when we do the marrow, we try to see whether is it empty or there are cancer cells on it. Okay. I'm not going to get into details of marrow in this one. Coming to the practical approach. You have someone with anemia. Whom should you evaluate thoroughly? I told you weight loss, liver, spleen, lymph nodes enlarged, WC platelets abnormal, recurrent, requiring transfusions. You know, you have to evaluate thoroughly. First episode, somebody has come to you with anemia. Okay, small RBCs, MCV is small. If possible, do ferritin, get a diagnosis of iron deficiency, and treat. But if they recur, do at least B12 folate. Okay, do LFT, look for liver disease, bilirubin, globulin, maybe high in myeloma, creatinine, and going further, any of these are there, you have to do bone marrow test. So first episode, at least do ferritin. Recurrent episodes, maybe it's additional. Also look at the do a bone marrow. So this is basic approach. What do we mean by further testing? Okay, now let's look at what is expected anemia. I'm repeating this over and over again. Expected iron deficiency means poor dietary intake, young child looks malnourished, sure, or rapidly growing teenager, sure, recent menstruation has started, young woman, sure, expected iron deficiency, right? Or in pregnancy, expected iron deficiency. What it expected B12 folate deficiency? Strict vegetarian, right? What is unexpected? Unexpected. That means somebody is having anemia not in childhood or youth, but when they are more than 50 years of age. Why will somebody get iron deficiency beyond 50 years of age? Don't just leave it with iron deficiency. You need to evaluate further. Or postmenopausal woman getting iron deficiency. Why would she get? Maybe there is a colonic malignancy where there is microscopic blood loss. Okay. Postmenopausal women, age men more than 50 years, first episode of iron deficiency, not expected. You don't just treat, you evaluate further, especially if there are other features, weight loss, recurrent. Do biopsies. I don't do this stool occult blood. I don't do it at all. I don't think it's a sensitive test. I generally do at least an ultrasound abdomen and an upper lower GI scopies. Okay. Of course, poor patients or patients who don't want to evaluate, doctor, I can't do this, no problem. You do stool occult blood, but it's not a very sensitive test. And no patient gives 3 samples or 5 samples. So if you have any of these issues unexpected, please do endoscopy. You don't want to miss a colonic malignancy and later on it becomes metastatic. It's heartbreaking. And if the scopies are okay, the biopsy will tell you if there is H. pylori infection. Gut biopsy will tell you if there is celiac disease, you know. And if these are negative, there is still iron deficiency, then I look for rarer causes such as PNH, where I'll do blood test for paroxysmal nocturnal hemoglobinuria. So this is how you start with the first episode of iron B12 doesn't get well. What do you look for? Look at LFT, creat, LDH, etc. Doesn't get better. Any high risk markers are there, right? How do you evaluate further? You do scopies, you look for PNH, and when do you do a bone marrow test? Okay. Recurrent B12 deficiency, look for pernicious anemia. There are wonderful blood tests available now, anti-parietal cell and anti-intrinsic factor antibody. I told you when to do a marrow. Hemoglobin mild anemia, you don't have to do. Once it goes to moderate, hemoglobin less than 8 grams, no obvious hemorrhage, Sure, MCV is low or MCV is high. You're thinking of nutritional, no problem. Get your pathologist to see the smear, do ferritin, B12, folate if possible. Treat accordingly. You don't need a bone marrow test. Okay? But if anything else is there, icterus is there, there is high bilirubin, maybe it is hemolysis. Okay? You have to do more tests, do a full LFT, LDH, figure out if it is hemolysis. B12 folate, I told you the red cells break in the bone marrow itself, intramedullary hemolysis, which will increase the LDH. It will also increase the indirect bilirubin. Okay, so in B12 deficiency, you will get slightly low WBC, slightly low platelet, bigger RBCs. LDH is increased, and slight indirect bilirubin is about 3 grams or 5 grams. Okay, it's not going to be 8 or 10 milligrams of bilirubin. It's going to be 3 to 4 milligrams of indirect bilirubin. Yeah, again here you don't need a marrow exam, but if things are really not good, WBC's platelets are down, liver, spleen, lymph nodes, you suspect a marrow problem, do an early hematology consultation, do a marrow. Or platelets have also gone down, you can't explain it by anything else, you may have some abnormal cells, please do an early marrow. What about treatment? Iron deficiency, oral treatment you can give to everyone. You start oral, just give it once a day or alternate day. Don't give iron tablets 2 or 3 times in a day. It does not help. It does not help. In fact, research shows that giving it alternate day is better. Absorption is better. Okay, so oral iron, give once a day or alternate day. You can use any drug. You can use ferrous fumarate, sucrose, whatever. It doesn't matter. Whatever your patient can tolerate. There are so many brands. Our experience is ferrous fumarate, that is Livogen tablet, is tolerated by many, but sometimes they don't tolerate. Some patients tolerate, sucrose better, right? So whatever your patient can tolerate, don't worry. Don't worry whether you take it before food, after food, morning, night. It doesn't matter. Don't break your head about all that. Give it once a day. Some patients have GI intolerance. They may have gaseous irritations. They may have diarrhea. They may have constipation. And they say, no, doctor, if I take it in the morning, I don't have problems. I tell them take it in the morning. Some people say, doctor, if I take it at night, I don't feel any problem. Take it at night. So it doesn't matter. Any formulation that you want, that your patient tolerates, you give once a day or alternate day. Don't break your head too much. Use IV iron. Now we have fantastic IV iron. Please avoid iron sucrose. We get quite a few reactions in that. I've had one death with that many years ago when I was a resident in medicine. But the newer iron, polycarboxy maltose or isomaltoside, tolerance is good. You can give IV iron, right? You give it if somebody is not tolerating oral, or they have celiac disease, or they have had a gastric bypass surgery. So oral iron, you're not going to get absorbed. So in these patients, you please use IV iron, feel free. And some patients say, doctor, I don't want to take tablets, oral iron for 6 months and 1 year. Give me 2 injections of IV. Sure, no problem. You can do that, but it's not necessary for everyone. There's also some data that in pregnancy, IV iron polycarboxy maltose or isomaltoside gives faster increase in hemoglobin than oral iron, even faster than injectable iron sucrose. Yeah. So these are the indications for oral and IV. B12 deficiency for vegetarians, they need treatment lifelong. Okay. You have to give at least 1,000 microgram of the injection, and you can use the pure form methylcobalamin, etc., or you can use the other brands, neurobion, optineuron, whatever has at least 1,000 microgram. I use neurobion or optineuron because it is cheaper. It's cheaper than the purer form. So I use this as long as it has micrograms. You give it IM, but like I told you, in B12 or folate deficiency, even the platelets may be low. So if you give iron, IM, there may be a hematoma, muscle hematoma. So when the platelets are below 50,000 and it is B12 deficiency, then we give it deep subcut, not intramuscular. Many times the nurse or doctor will say, no, no, the injection says only for IV on or IM. Don't worry, you can give it deep subcut. Okay, platelets are less than 50,000, give deep subcut, press for nice 5 minutes, nothing will happen. Don't give intramuscular if platelets are low. Now, this is the conventional regimen you give daily for 1 week, weekly for 4 weeks, monthly for 3 months. Nobody has done research on whether we should use this or something else. Nobody knows. If there is no pernicious anemia, no celiac disease, absorption is not a problem, then you can also use oral tablets, 1500 micrograms, but they have to be taken daily. Okay. So this, initially daily, then weekly, then monthly, but the tablets have to be taken daily because the absorption is very less. So this is how you can treat B12 deficiency in expected patients. When unexpected deficiency, that means not a strict vegetarian, or there is B12 deficiency is happening for the first time in 30, 40 years of age, don't assume it's just nutritional. Okay. Do upper GI scopy, rule out pernicious anemia. Rarely you may even be able to catch a stomach cancer which is leading to this. Okay. So remember, expected, unexpected. How do you follow up? Iron deficiency, you've just suspected, you've not done ferritin, but WBC platelets, okay, liver spleen, okay. You thought, hey, this is iron deficiency, I'm only going to give tablets. No problem. Okay. If hemoglobin is less than 5 grams, cardiorespiratory problems are there, give blood transfusion. In nutritional anemia, if the patient is stable, we do not give blood if the hemoglobin is more than 5 grams. Why? Because with iron B12 in 3-4 days, hemoglobin will start coming up and the patient becomes stable. So if it is clear-cut nutritional iron B12 folate and the patient is stable, you can wait until hemoglobin goes to, drops below 5 grams. You don't have to transfuse. Okay. You've treated, you've given transfusion if required, repeat CBC. Initially, you watch it closely every 2-3 days, then once a week for a month. And if the hemoglobin is increasing satisfactorily, in 2 to 3 weeks, nice 1 gram increase, 2 grams increase. WBC platelets are also coming up if they were low because of B12. Great. Nothing to do, no further tests are required. Continue treating as iron deficiency, okay? But check CBC. Give iron not just 1 or 2 months, but minimum 6 to 12 months. Very important. Before stopping, don't say, hey, hemoglobin is 11, you can stop iron. No. If you want to stop, you have to check ferritin. Okay? When you give iron in an iron deficiency patient, okay, it is like there is no iron in the body. It is like a poor person where there is no money. There is no money. You start oral or injectable iron, you are giving some cash, and that cash will increase the hemoglobin. Okay, but you have to keep on giving iron for 6 months, 12 months until not only the hemoglobin but even the stores of iron, that is ferritin, go up. Inadequately treated, 1 or 2 months of iron, then stopped, again 2 years later, they'll come back. You treat them properly for 6 months to 12 months. It is like increasing the fixed deposit, not just giving cash to a poor person, but regular employment, regular salary. So there is cash in the pocket and there is money in the bank and there are fixed deposit, that is ferritin. Okay. So give treatment for proper duration, and after 6 months, etc., if the ferritin is okay, 6 months, 12 months, you can stop. However, if the HbWBC platelets are not improving in 2-3 weeks, then see if you should give B12 folate, do an LFT, create LDH. Think, should I do a bone marrow, or should I wait? At least think about these things. This is how you follow up. What about blood transfusion? Like I said, clear cut iron B12 folate, stable patient, you don't have to give if the hemoglobin is more than 5 grams. But elderly, coronary issues, unstable, breathlessness, please transfuse. Don't wait for 5. Below 8, you transfuse. Okay? So, in some patients, when they are unwell, they have comorbidities, even less than 8 grams, we will transfuse. Okay. And if you want to transfuse, please take off one ferritin, B12, and folate sample before that. Uh, like I had said in the beginning of this talk, don't worry if you have to do a bone marrow, your blood transfusion is not going to affect the bone marrow report. Steroids will. Yeah. Uh, uh, yeah, steroids will. But blood transfusion is a clinical decision. You have a patient with low hemoglobin, unstable. Go ahead and give blood. Don't say no, no. We will hold blood. We will do bone marrow tomorrow. Then we will do blood. No, blood is life saving. You give it off, right? What about if it comes back recurrent? Sure, recurrent iron deficiency, malabsorption, celiac disease. Sometimes you have missed B12 folate by only treating iron deficiency. Sometimes there may be renal failure, hypothyroidism, as a question was asked, right? Or there is underlying cirrhosis, hypersplenism. All of these are common causes of recurrent anemia. Rarer causes, some patients take Pantocid or Rantac for years. And with those proton pump inhibitors, the acidity in the stomach goes down and iron does not get absorbed. So rare cause of recurrent or chronic anemia, iron deficiency might actually be chronic misuse of proton pump inhibitors like pantoprazole or omeprazole. Don't, if it's recurrent, look at the gut. Maybe absorption is an issue. Maybe it's a marrow problem, like I said earlier, and then rarely there is PNH or some other infiltration. Now, there are two cases. I don't know if we should do this or should we do this again next time, because we've had quite a long 1 hour, 49 minutes. What do you want to do? Should we go through the two cases or should we do it next time? Any suggestions?
We can do so.
We can do? Okay, these are small cases. So, they're not going to be too tiring for you. But they're representative cases. So let's look at a 37 years old lady. Yeah, she's 37 years old. So she's not new menarche, menorrhagia. She says, last 5 years, doctor, my hemoglobin has been low. You ask, okay, how low? What is the lowest? 6 grams. Okay, so that's serious. Fine. What are you going to do? Obviously, you're going to do a CBC. You're going to see the hemoglobin, yeah, 5.8, but WBC is okay. Differentials okay. Platelets are high. Now you will start thinking, yeah, Dr. Sachin had told me in iron deficiency, reactive thrombocytosis can happen. There can be high platelets. All right. So what next? You start looking at the RBC indices. Yeah. MCV is small. Must be iron deficiency, microcytic. RDW is also more than 17. Must be iron deficiency. What are you going to do next? You can start iron treatment, or because this is severe, I will do a proper testing. So I'll do a ferritin less than 25, iron deficiency. Okay, straightforward. Now, but this person tells me, no, no, doctor, but I keep on taking iron tablet. I'm okay for a few days. Then you ask, do you take it properly for 1 year or you stop after 1 or 2 months? Do you have bleeding? No bleeding. Okay. Do you take it properly for 6 months, 1 year? No, doctor, I don't take after 1 or 2 months, I stop. Okay, no, you should take it properly. We have to fill up the stores. Ferritin has to go up. All right. But nevertheless, it's recurrent. You're 37, years old. You're coming to the border, still of childbearing age. But still, I'm going to do stool occult blood and I'm going to do an LFT. And the LFT now starts showing something. You see, the bilirubin is slightly high, and this is indirect bilirubin. Then you will remember, yeah, in B12 folate deficiency, the RBCs can break inside the marrow because they are not maturing, leading to mild indirect hyperbilirubinemia. Maybe along with iron, there is B12 folate which has not been diagnosed, it has not been treated. LDH is also high, normally is about 240, must be B12 folate, right? However, in this patient, the B12 folate was normal. So, when bilirubin goes up, it is possible that there is hemolysis because of B12 folate. it is also possible that that is a hemolytic anemia. There is one hemolytic anemia called PNH. In PNH, what happens is the RBCs break and the hemoglobin is lost in the urine. Hemoglobin is lost in the urine. So here blood loss is not menstrual. Blood loss is not in the bowel. It's in the urine. Okay. Sometimes patients may say, yeah, doctor, sometimes my urine is brown, cola colored, right? Hemoglobin urea. So recurrent, and because hemoglobin is lost, blood loss is there is iron deficiency. So like GI blood loss can lead to iron deficiency, urinary blood loss can also lead to recurrent iron deficiency. And this is a cause of that. We get this pretty common, every 2-3 months we diagnose a patient of PNH, and it's a simple blood test for PNH. And in this patient, the diagnosis, the cause for recurrent iron deficiency was paroxysmal nocturnal hemoglobinuria. Because there's iron deficiency, of course, we supplement iron, but some of these patients can get thrombosis, DVT, okay, pulmonary embolism, mesenteric thrombosis. Some of them can later on get bone marrow failure, aplastic anemia. So if later on they get aplastic anemia, we have to do a bone marrow transplant. But otherwise, we only give iron, and then there are some newer medicines if they have thrombosis and hemolysis. So this was the first patient, and this lady later on developed aplastic anemia, so we had to do a bone marrow transplant. Second case, younger boy, okay, 7 years old boy, infection, fever. So you see, this is not clear cut anemia. This is not clear cut anemia. There is fever. Maybe young boy iron deficiency with viral fever. That is also possible. Possible. But fever is not a symptom of anemia. There's something wrong. There's an infection. Are the WBCs okay? So then we look at that. No, the WBCs are high and the lymphocytes are high. But then you will think, yeah, but young boy, normally they may have higher lymphocytes. Okay. But the platelets are low. Why are the platelets low? If this is iron deficiency, you know, platelets and WBCs have to be normal. Then you may think, well, maybe this is B12 deficiency. In B12, platelets can go down. But then even the WBCs have to go down. Correct? So something is not gelling here. Nevertheless, B12 megaloblastic, you have at the back of your mind, there is anemia, low platelets. You look at the MCV, yeah, MCV is also high, 93. It's not crazy like autoimmune hemolytic anemia, 120. 93, maybe megaloblastic anemia. Okay. But you're not sure why these WBCs are high. You examine the liver, spleen, lymph nodes, they are okay. You call your pathologist, they say, yeah, the RBCs are bigger, it's macrocytic, you know, and then you think, okay, but he's a bit sick, fever. So you do LFT create, LDH is high, maybe B12, correct? So you do B12, and B12 is 110. I forgot to tell you, iron deficiency means ferritin less than 25. Simple. B12 deficiency means ferritin less than 250. So 25, 250. Folate deficiency means folate less than 5. Okay. So folate level less than 5, serum folate. Serum B12 less than 250, B12 deficiency. Ferritin less than 25, iron deficiency. So yeah, this kind of gels, B12 low, LDH is high, platelets are slightly low, WBCs are high, maybe the fever infection. Sure, I'll treat as megaloblastic anemia, no problem. So I treated as vitamin B12 deficiency. I gave injections daily for 7 days. I avoided blood transfusion because young boy is stable, does not have severe anemia. My cutoff is 5 grams for nutritional. But then I kept a close watch. And after 3-4 days, 1 week, I'm seeing that WBC is not really improving. I mean, platelets are not really improving. WBCs have also, our hemoglobin and platelets both are not improving with my injection. That means the response is not there. At that point, you have to think of an alternate diagnosis. So this is where I say, no, there is a delay in response. I have to do a marrow, right? Again, there are some atypical things. The WBCs are high. So we did a bone marrow. It showed atypical cells. We did a flow cytometry to find out what are these atypical cells. And it turned out to be a ALL, acute lymphoblastic leukemia. You see, bone marrow packed by bad cells, bad workers, hemoglobin platelet production has gone down. Some of the bad cells have come out in the blood, hence the WBC counts have gone up. Yeah. But young boy, ALL, excellent chance of cure. We do genomics, we give him good treatment protocol, and the chances of cure are great. So this is how we this is a practical approach to your patients with anemia. What are the high alert features that you should look for? How you can go stepwise, increasing the evaluation wherever you feel that the responses are not good, and what are some causes of refractory recurrent anemia. Thank you.
Sir, thank you very much, sir, for your
You're welcome.
nice representation and excellent this things teaching. Sir, can I
Thank
get the this thing, sir? Videos and the
Yeah, yeah.
PPTs.
So, it takes me a day to process the videos. I will
Mhm.
then upload them on YouTube, and I'll share the YouTube link with all of you.
Okay, sir. Thank you very much, sir.
Yeah. So just a couple of questions and then we will close. I'm also tired. This we completed. We completed this. So in Dr. Sukhveer
Sir,
Singh is asking why initially we treat iron deficiency, then WBC and platelets go down. No, then there is something else that is wrong. This doesn't happen in iron deficiency. Either you're missing a B12 folate deficiency because of which WBC platelets are going down, or there is something wrong with the marrow. What happens to MPV in giant platelet? Of course, it will be larger. Hypothyroid, low metabolism, agglutination, hypersegmented neutrophils. Yes, polymorphonuclear leukocytes or hypersegmented neutrophils. How many days to wait for recovery after B12 supplement? Generally, in the 4 5 days, the hemoglobin will come up. Generally, in a week, the WBC platelets will start improving. So, if platelets are 30,000, they'll become 35, 40. But by the end of a week or so, if you're suspecting B12 folate deficiency, you've given that treatment and WBC platelets are not improving, go ahead and do a bone marrow test. Okay, don't wait. Duration of oral iron minimum 6 to 12 months. You can check ferritin and stop. Um,
Sir, in case of this low hemoglobin below 6.5, you had said that transfusion should be considered. Do we do that even if the patient is not in failure, or only if the patient is in cardiac
so
failure only we should consider?
if it is not iron B12 deficiency, if it is not autoimmune hemolytic anemia, then anybody less than 8 grams we transfuse. Okay,
Okay, okay,
so your cutoff for transfusion is 5 grams and 8 grams. Yeah.
okay,
Iron
okay,
deficiency, B12 folate, and autoimmune hemolytic anemia, 5 grams. Everybody
okay,
else, whether it
okay,
is whatever is the cause, 8 grams is the cutoff. Comparison of different iron preps and GI intolerance, it doesn't matter. Yeah. Different patients will have intolerance to different drugs. Folate deficiency, I didn't speak much because it's very simple, and isolated folate deficiency is rare. Features and others causes are very common, similar to B12. Treatment is 5 milligram of folic acid tablet for at least 6 to 12 months. Again, um, all right. I think so. When B replace B12, there are leg cramps. Yes. Oh wow! Amazing observation by Dr. Bhuvaneshwari. When you give B12 and folate, suddenly all of these cells in the bone marrow, they will start maturing, and when they mature they will start coming in the blood, and they will, the serum potassium will become intracellular potassium. So this is a phenomenal observation by Dr. Bhuvaneshwari, that in B12 folate deficiency, when you're giving treatment, After 3 days or 5 days, also check serum potassium. What we do is we just tell the patient to have 2 bananas every day. Okay. Uh, any contraindication of blood transfusion in ITP? No, you can get packed red blood cell in ITP. No problem. All right. So I think we are done. Thank you, everyone. I'll share the post test, and I will today in the group I'll put the post link to the post test and other video and all that. Hopefully by tomorrow evening. Wonderful. See you guys again on Friday. And please post your questions in the WhatsApp group. If there is a patient that you want to discuss, please call me because I see WhatsApp once in 3 4 days, right? So I may not follow your question. If you want to discuss a particular patient that you have, just call. See you guys. Bye.